Hi, Dr. Bhargava here. I have several interesting cases in this video to share with you all. This is our first patient, and they came in with a history of a lung nodule, and a whole body FDG PET CT was performed for evaluation of the lung nodule. Let's start by looking at the rotating image. All right, so this patient has a nodule in the left upper lobe of the lung, which we see right there. It shows focal hypermetabolism on the fused PET CT image, and there is no other evidence of focal hypermetabolism to suggest presence of metastatic disease. So this lung nodule or cancer is treatable and resectable. The interesting finding here is that there is this focus in the left side of the face. This corresponds to a soft tissue density inside the parotid on the left side, as we see here, and this is a common finding, and these turn out to be benign prostatic tumors like Warden's tumor or pleomorphic adenomas. This is this patient's CT, which shows the tumor in the left upper lobe. Also, it shows emphysematous changes in both lung fields from smoking. This is our next patient, and we are looking at multiple images from their MR of the abdomen, trying to evaluate a lesion in their left adrenal. So on the coronal image, we find that this is a simple appearing cyst because there is T2 hyperintensity, also seen here on the fat saturated axial T2 weighted image, and there is no enhancement on the contrast enhanced image. So simple cysts are not very common but can be seen in the adrenal. This is how they would look on MRI, and they will not show restricted diffusion on DWI and ADC images. Here's our next patient. They presented with jaundice, and a MR of the abdomen was performed. On the left, we have a coronal T2 weighted image. In the middle, we have a reconstructed MRCP image, and on the right, we have a MRCP image also. So they have intrahepatic biliary ductal dilatation, they have extrahepatic or CBD dilatation, and as the CBD approaches the ampulla, there is tapering, and in this situation, we worry about a tumor. No tumor was seen on the MR, and no tumor was found on the ERCP, but a biliary stricture was found, and it was treated by dilatation during the endoscopy procedure. This is our next patient. We are looking at PA and lateral views of the chest, and here the cardiac silhouette appears large. If we did a cardiothoracic ratio, definitely there is enlargement of the cardiac silhouette. We see the same finding here. The cardiac silhouette is enlarged, and on their CT we find that there is left ventricular hypertrophy. When the free wall is more than 2 centimeters, that's a good criteria. More than 2 centimeters in thickness, it's a good criteria to call left ventricular hypertrophy. So on cross-sectional imaging, frequently the trainees would call cardiomegaly, but technically, since it is cross-sectional imaging, we should comment on whether the cardiomegaly is because of hypertrophy, dilatation, or a combination of both hypertrophy and dilatation. So this patient also has some perihilar vascular congestion and small bilateral pleural effusions, suggesting mild congestive cardiac failure. This is our next patient. We are looking at a CT image and multiple images from their MR. And so when you're reading the MR, what would you think of this focus of non-enhancement? On all the phases, we got non-con, arterial, portal venous delayed, and a more delayed phase. And this focus right here of absent signal on T2 weighted images. So when we correlated it to the CT, we found a focus of calcification. So remember, calcifications will not have any signal, just like a focus of air will not have any signal on T1 and T2 weighted images, and it will appear black. Similarly, a focus of calcification will also have no signal and appear black on both T1 and T2 weighted images on MRI. Here is our next patient. We are looking at anterior and posterior whole body images from a whole body bone scan, and they have these multiple foci of increased uptake suggestive of osteoblastic bone metastases. Surprisingly enough, the primary here is a renal cell carcinoma, and we know that renal cell carcinoma causes lytic metastases, and in lytic lesions there is rarely intense uptake. There is some uptake which is at the interface of the lytic lesion and the surrounding normal bone, but here we find that these lesions are osteoblastic. And so bone mets from renal cell carcinoma. This is our next patient, and here the finding was incidental. On the axial, coronal, and sagittal images, we find that the IVC filter has moved superiorly. Usually it's placed at this level, and sometimes the struts go outside the IVC. That's okay. It may appear very dramatic on imaging. Sometimes it's, they may abut or protrude through the wall of the aorta also, or maybe a bowel loop. And most of the times, if there is no surrounding inflammatory reaction, then there is nothing to worry about. This IVC filter, however, has moved superiorly into the intrahepatic portion of the IVC, and it needs to be removed. And I think interventional radiologists can go through the internal jugular vein to the right atrium and pull it out in that direction. So that was performed to take this IVC filter out that had migrated from its normal location to the intrahepatic IVC. These are images from a 3-phase bone scan. We are looking at blood pool anterior image of the pelvis, blood pool posterior image, and then a delayed anterior and posterior image. And on the delayed image, we find that there is increased periprosthetic uptake. They have this photopenic defect in the left hip. And so the left hip on the blood pool image would be here. So there is no hyperemia. But on the delayed image, we find that there is periprosthetic increased uptake, which is patchy or multifocal and mild in intensity. And so something like this would be consistent with aseptic loosening. This patient did have a indium 111 WBC scan, which did not show any abnormal uptake to suggest presence of any associated osteomyelitis. Here's our next patient. This patient underwent a Dorotate PET CT for staging of their neuroendocrine tumor. Let's start by looking at the rotating image. So here we have lymphadenopathy in the mesentery that takes up the radiopharmaceutical. So this is its appearance on the CT, and it shows increased uptake. And this is their primary in the distal small bowel. And this focus right here in the pelvis is a deposit on their left ovary. This patient came back for a follow-up. This is their follow-up study. And on the rotating image, we find that there are multiple foci of increased uptake throughout the intraperitoneal compartment, suggesting peritoneal carcinomatosis from their neuroendocrine tumor. So there has been disease progression. We find that the uptake in the lymphadenopathy in the right lower quadrant is seen right here, and there is interval enlargement in the size of the left ovary and the tumor deposit that is seen there. And so when the tumors from GI primaries metastasize to the ovary, that's called a Krukenberg tumor. And so this is a great example of Krukenberg tumor of neuroendocrine origin with disease progression leading to carcinomatosis. Here's our next patient, and we performed a PSMA PET CT to stage their prostate cancer. Let's start by looking at their whole body image. We see physiologic uptake in the lacrimals. We see faint symmetric uptake in the salivary glands, liver more intense than the spleen, physiologic excretion from the kidneys into the urinary bladder. And below the urinary bladder, we see these multiple foci of increased uptake in the prostate, suggestive of multifocal prostate cancer. Right there, the prostate is enlarged on CT, and there are multiple foci of increased uptake. There is no evidence of metastatic disease, and so patient's stage is limited, and based on the stage, they can undergo treatment. This is our next patient. They underwent a CT of the abdomen and pelvis where we see an incidental finding of distended gallbladder on the axial, coronal, and sagittal images with calcified walls. And so this is a porcelain gallbladder, and this patient should undergo a cholecystectomy. Porcelain gallbladder is seen more commonly in older women who have had gallstones and chronic inflammation from gallstones for years, which has led to calcification of the wall. And these patients are also at the risk of developing gallbladder cancer, and so a cholecystectomy is recommended. This gallbladder is full of stones, but the stones are not hyperdense, and so they're not seen on CT. They would be better visualized on ultrasound. This is our next patient, and they presented with urinary symptoms and scrotal swelling. We performed a CT of the abdomen and pelvis, and the findings are related to ascending infection, where we find that the testicle on the right side is enlarged and hyperemic. There are prominent vessels in the right spermatic cord. Incidentally seen are bilateral small fat-containing inguinal hernias. Another view of the enlarged hyperemic testis and the epididymis, and also infection of the right-sided seminal vesicle. It is enlarged and there is surrounding fat stranding. And so a good example of ascending infection of the urinary tract through the urethra to involve the urinary bladder. This one does not show any findings, but that's okay. There can be no findings even with infection on the CT, but we do see findings suggestive of seminal vesiculitis on the right side and also epididymoorchitis. This is our next patient. They presented with a labial swelling, and the swelling was evaluated using an MR of the pelvis. So this is the swelling. It has same signal intensity as the subcutaneous surrounding fat. It is seen right here in the right labia and also right there. So on the fat saturated T1 weighted contrast enhanced images, it also has fat signal intensity and no enhancement and no restricted diffusion. So this is a benign lipoma arising in the labia. Here's our next patient. They presented with this fluid density lesion on the CT that was further evaluated by MR. And so on the T2 weighted fat saturated image, we find that this is cystic lesion posterior to the pancreas is simple. It is oval in shape. It has thin non-enhancing wall, no internal septations, and low T1 signal and no restricted diffusion. And so something like this would be a pancreatic pseudocyst, seen here and also seen here on the reconstructed MRCP image. Next patient shows an artifact at different levels on their CT of the abdomen and pelvis. Look at this linear hypodense focus, also seen right there and right here. This is called a ring artifact, and this suggests that one of the detectors on the CT scanner is not working. This is our next patient, and here on their MR of the abdomen, we found these round low signal foci at different levels, and these low signal foci were secondary to these calcified lung nodules and blooming artifact related to that. This is also called susceptibility artifact, and the correlation between the MR and the CT led to recognition of what was causing these artifacts that were seen on the contrast enhanced T1 fat saturated images from their MR. This is our next patient. They presented with left lower quadrant abdominal pain, and in the left lower quadrant on their CT of the abdomen and pelvis, we see this focus of fat that is surrounded by fat stranding. Also seen right here, a loculated focus of fat with some enhancement and surrounding fat stranding. And if you pay attention inside, there is a linear focus. This linear focus is a thrombosed vein, and this focus of encapsulated fat is abutting a wall of the colon. And so this finding is epiploic appendagitis. Epiploic appendages are fat-containing structures that line the outside of the colon, and sometimes they can get inflamed, and inflammation can lead to abdominal pain, and their appearance here is characteristic. We call it epiploic appendagitis. On one of the projections, either axial, coronal, or sagittal, you will find a linear hyperdense structure inside, which is a thrombosed vein. The management is usually conservative. This is our next patient. We performed a multiphasic CT of the liver to evaluate a tumor in the caudate lobe. And so the caudate lobe is seen right here on the non-contrast enhanced images. On the arterial face, it shows this round focus of uniform contrast enhancement. And on the more delayed images, we find that there is washout of contrast and there is a little bit of a pseudocapsule there. And so putting everything together, this is an LR5 lesion consistent with the hepatocellular carcinoma. This is our next patient. They were diagnosed with breast cancer while they were pregnant, and we performed a whole body FDG PET CT scan for staging. Let's start by looking at the rotating image. So they have this very large hypermetabolic breast cancer in their left breast, which is also seen right there. They have metastatic lymphadenopathy in the right axilla and in the right pectoral region. And then in the pelvis, we see this focus, linear focus of mild to moderately severe FDG uptake, which is also seen here at the site of scarring from their C-section surgery. So they were diagnosed with breast cancer at the time that they were pregnant, and then they underwent a C-section followed by staging for their breast cancer, and then they got the treatment. The other incidental interesting finding is that we put a port in their left chest wall, but the port is standing on the side. This is the part or the base of the port, and that base should be touching the pectoral muscle so that it can be accessed for injection from this side. So its position has changed so that it is probably not accessible and needs to be addressed. Here's our next patient. They presented with flank pain, and we performed a renal stone protocol CT. The kidneys are not shown here or seen on these axial, coronal, or sagittal images, but we do find a stone obstructing in the ureter. We see the dilated ureter partly superior to that right there, and also the stone right there on the sagittal. The location of this obstructing stone is important because this is where the ureter turns posteriorly as it is coming down. So it's at the level of the pelvic brim where the ureter so far has been coming down, but at the level of pelvic brim, it turns posteriorly in that direction. Right, and so that's the site of physiologic narrowing of the ureter, along with two other sites, one of them being a UPJ and the other one being the UVJ. And so those are the three physiologic sites of narrowing of the ureter where a stone usually gets stuck. So you can have a stone right here causing obstruction, a UPJ stone, a stone at the pelvic brim causing obstruction like in this patient, and also a stone that can be at the UVJ. Those are the three most common sites where you will find obstructing renal stones. Thank you for watching.